Welcome to Caring.
Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well.
Caring Well. Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well, a Middleton Pediatrics podcast where we have conversations to help you care well for your child. Today we have another conversation with Dr. Alejandro Jordan. He's been with us before and we're excited to have him back. As you may remember, he's a pediatric infectious disease physician, and he's going to share with us his observations from this year's 6th season. We're going to talk about measles, vaccines, and other things. So I think you'll enjoy, as before, all the things he has to teach us. So let's go to that conversation. Dr. Jordan, welcome back.
No, thank you so much.
Yeah, thanks for being a regular on Caring Well. I thought it'd be fun to have you back because we're kind of towards the tail end of our respiratory season. Obviously, it keeps going, and Florida is a little bit of a different type state where we get a lot of these things year round, but a lot of the intensity of the season has come and is going, and thought it'd be good to review some of those things. Talk about flu, I want to talk about measles and RSV, where we are with COVID, but I think flu is probably a great place to start. So just to remind everyone listening, you are a pediatric infectious disease physician. That is both inpatient, meaning in the hospital, kids admitted to the hospital, as well as outpatient clinic.
Yeah, correct.
From your perspective, how has this year's flu season been?
It's been a little bit, hard. One of the reasons is the vaccine didn't cover as well as other seasons. So in flu, every year what they try to do is, they have different labs around the world that try to track, how the virus is changing, and they try to predict what is the next strain, and they make the vaccine based on that. And for the most part, every year, it's about 70% that they kind of match the strain that is going to circulate. But this year, the vaccine didn't match as well. So we call that a mismatch. And the main reason is that as any virus or any bacteria, there are kind of changes. Like our bodies that we change all the time, our genes changes. So in the virus happen the same thing. So influenza has like 2 different big antigens on the kind of the surface of the virus. And every time they mutate a little bit. And then when they mutate, that antigen, which is the part of the virus that the immune system recognizes, changes. But the changes are really small. So they become like, one virus to another one, they're like family, they're relatives, but they're really close relatives because the changes are really, really small. But if the changes are really big, then they become like distant relatives. And that's what we call a drift.
So you're saying if the change is significant enough, it's referred to as a drift.
Yeah. So, one is the drift. So if the change on those kind of antigens with that like kind of proteins or, in top of the virus, that's what the immune system recognizes, is really big, it becomes a drift. It doesn't change the virus completely, but it will create a mismatch with the vaccine because the strain will be kind of different than the one that you were supposed to have, and we call that a mismatch. So what happened this year is that by the time that they came with the vaccine, then the change came, the drift came, and the virus was a little bit different. So it's still what we call, H3N2, but it changed. So by changing, that means that the vaccine didn't cover as well as they were, supposed to cover. There are other things on influenza. One is the drift, the other one is the shift. In the shift is when that change is huge, and then you have a novel virus. And usually, happens, from animals, you have that big change and then goes to humans. And because that change is able to transmit from human to human. And that what happened, if they remember in 2019 with the swine flu. So the swine flu was a shift. So that's a completely novel virus that nobody was,
so that was
around it.
2008, 2009.
2008, 2009.
Yeah, okay.
Yeah. So we have had in the past about like 3 big pandemics of flu. One is the Spanish flu, that's the big one.
It's 1918 thing.
1918, and then you have the Russian one, and then you have, the 2009 of the swine flu. So this year we didn't have a shift or a novel virus. We have the same virus, but it changed a lot.
Okay.
So the vaccine, instead of covering what usually covers about 68, 70%, now it dropped to about, 40% coverage. And that's why we see so many cases.
You have some years where it's matched well. And it's matched well because there hasn't been a drift.
Exactly.
And then some years you have the drift, and so it's going to be more of a mismatch. And then thankfully, rarely, but it does happen, you have this shift, and that's when you have more of a global flu pandemic
Yeah.
type thing.
And the flu pandemic is because since it's a novel virus, nobody,
Your
the
existing
people has
immunity.
not been exposed to, so there is
Okay.
not existing immunity. So for us will be a new germ or a new, infection that our bodies has never seen. So we start from the scratch to develop that response against
Yep.
that virus. And that's what it causes, the pandemic. What happened with COVID-19 was
Right.
a new virus. So nobody was able to recognize it really fast in, the immune system. And that's what you get,
And so like going back to the swine flu, and some people would hear it and think it's not a new virus because it's the flu, but there's so much, it's so different than previous flus. Effectively, it's a new virus.
Yeah.
Okay.
Because, it's a little bit what happened last year, or this year, between, 25 and 26, that people was concerned about the avian flu, the H1, H5N1. So it didn't become a pandemic because although there were few cases in humans, it was not continuous spreading from human to human. But it's kind of the same concept. So you have a virus that is usually seen in animals and is able to jump to humans, makes that big change, and is able to transmit from humans to humans, and then becomes a pandemic or becomes a big, outbreak and things like that. So even though the vaccine didn't match completely, it still worked.
And it really didn't, because I do think a lot of our families know kind of flu A, flu B. And so the drift you're talking about, the mismatches among a type of A strain,
correct,
the H3N2 strain, that it was wasn't matched as well. So you were starting to say didn't prevent as much illness, but still.
Yeah, so the vaccine didn't match completely, but it still was able, to decrease the amount of emergency visits and admissions to the hospital. So even though it's not a perfect match, it still works. So, even in cases when you have this major drift, still vaccinating is a good idea to prevent severe disease. So with respiratory viruses in general, you don't have a vaccine that prevents the disease completely. It's not like measles, that we're going to talk in a little bit, that, about 97% of people, when they get the vaccine, there is 97% protection.
Right, from getting it at all.
At all. So
right.
It's almost 100% protection not to get it. But in respiratory viruses, it's really difficult to achieve that high protection. So the majority of the vaccines are designed to decrease severity of the disease. So you may get the virus, but the virus is going to be mild. So you can stay home. You're not going to end up in the emergency department, in the ICU, admitted with a severe infection. So even with a mismatch, the vaccine was able to prevent, around 40% admissions to the hospital and to the ICU. Now, flu vaccine has never been perfect. So in a good year, we have about, 60%, 65% effectiveness. But it's better than having 0%.
A question that we get, and I'm sure you get, and I think it probably is wondered even more than it's actually asked. Someone says to you, listen, my child is healthy. Often the flu vaccine isn't that well matched anyway, like this year. It seems like most years when I haven't gotten the vaccine, I still didn't get the flu. Why should I get it? Why even get it if all these things? And how do you respond to that?
So I think when we look at vaccination, we have to look at two components. One is the protection of the one that received the vaccine, and the other one is the protection of the people that is around you. So even though you may say, why I'm going to get it if I never get sick? But maybe you are your grandfather or your relative, they are immunocompromised, they have cancer, they have these diseases. By protecting myself, I'm protecting the people that is around me. So I think that's one of the things about vaccination. So it becomes like an altruist thing to do, for everybody around you.
For the good of the community.
For the good of the community. But the other thing is that even though you're healthy, you may end up in the hospital with a really severe infection in the ICU, maybe requiring some, additional help to be able to breathe, even if you're completely healthy. So obviously these respiratory viruses, there are certain comorbidities that put you at risk. But even if you're completely healthy, you still can get severe disease.
One of the ways flu gets you, even though it can do it itself, but one of the ways is it sets you up for a secondary bacterial infection, and then the severity increases even more.
So if you protect yourself with the vaccination and you protect a severe case of it, then you are protecting yourself to maybe even get a super bacterial, infection.
This year, I think so far, we're not out of the flu season actually yet, but so far I think they're classifying it as a moderate season. I think last year they classified as a high. This year may end up being high. And I think maybe for kids, it actually was considered high severity. And maybe general it was moderate. But anyway, they have these classifications based on outpatient visits,
Outpatient
hospital,
visit, ED visit, admissions,
and
and,
then
obviously
deaths.
death.
Yeah.
Mhm.
Okay. And then last year, tragically, was one of the highest pediatric death rates in a while. I think
Mhm.
over a decade or something like that. Yeah. So really, your answer to the question would be, we don't expect it necessarily to prevent illness, but it does. It's very protective against severe cases.
Yeah, so for respiratory, viruses or vaccines for respiratory viruses, you're not looking at prevent 100% not to get it. You're looking to prevent those complications of the viral infection.
So we've had two, and really more than two, but we've had two consecutive tough flu seasons. Is your opinion just that is random variation? Because that does happen. Or is it we've also had lowering rates of flu immunization?
This year, we got a really low immunization rate. So when you look, about max 40% of the people got immunized. So it's really, really low. You look at past year, it's about 60% immunization rates. So that obviously contributes to more kind of severe cases, more admissions. I think that the changes is really random changes of the virus where you have a drift. And there are some years that you're going to have, as I said, a better match with the vaccine than others.
Speaking of influenza, if it is, and it is a relatively common illness, are there any things that if a family was saying, how do I know when I should be worried that this may be the beginnings of a more severe case? What might that look like?
So we get as well a lot of those questions in the office. Majority of the family are really worried about the fever. How high the fever it is, and we try to explain to them that fever by itself is the first kind of response the immune system has against infection, and the severity of the fever really does not correlate with severity of the disease. So things will be common things like, if your kid not eating anything, is not drinking, is not making any urine, you see that he's kind of lethargic, sleepy, doesn't wake up really easy. Is having a lot of, for example, diarrhea, if it's a diarrhea illness and he's not able to keep up with the hydration, difficulty breathing. Those are the things that you should, run and go and seek for, to be evaluated really, really quick. But if we have a kid that is, fever, between the fever episodes, they are back to, quote unquote, their self, and they are playful, and they're being able to keep hydrated, and they are making really good urine, and they don't have any problems, breathing. That's a kid that you can monitor at home.
Yeah, it'll sound self-serving, but I definitely feel like in one way the answer to it is we'll be in dialogue with your pediatrician. That would be one. And then the other thing we will say frequently is as you get further into the illness, if you are continuing to worsen, that's a red flag to us. It's pretty normal for flu to persist for 7, even 10 days, but it usually isn't worsening at day 7, worsening at day 8. It's just hasn't resolved yet.
Yeah. So when we see a lot of kids with, prolonged fevers, and we try to explain to the parents that those viral illnesses can give you fever for 7 to 10 days. And that's expected. Sometimes we see even viruses that give you fever for 4 to 6 weeks.
As an infectious disease expert, do you have any guidance versus soap and water hand washing versus instant hand sanitizer?
So I think soap and water probably is the best because you will cover everything. That's right. The hand sanitizer is probably the easiest, but it doesn't kill all the viruses, or in some cases all the bacteria, for example. So I think that in the hospital we use a lot of kind of sanitizer because it's easy to go from room to room, except when we know one specific disease, and at that point we go and do completely hand washing. I think that for kids that are in the school, it's probably I don't think that they can carry a hand sanitizer on the pocket. So probably frequent hand washing probably will be the easiest. If you ask me one thing, it's probably easier to do the alcohol kind of sanitizer really frequent than go and find a restroom to wash your hands all the time.
Just for clarification, there's all the products that are out there about helping you not get sick, not get these viruses, or get over the virus so much quicker. And I'm not talking about prescribed things like antivirals. I'm talking about over-the-counter immune boosting vitamins and other things?
That's all advertising. It really doesn't have any clinical evidence that protect. I think that if you have a good nutrition, that's more than enough.
The CDC recently said something about, I think the quote was something, I won't get this exactly right, but it was something like the flu vaccine didn't work very well. It was worded in a way that we felt like was so misleading and poor. And so not necessarily speaking to that statement, but just public health messaging as it relates to vaccination. Is there anything that you feel like you would love to see done differently?
One of the issues that we have right now is a lot of the vaccines that used to be highly recommended, now they are being changed to these
Shared decision
making. And I think by saying the shared decision making may indicate to some people that, maybe it's not as important because they are not recommended. And I think it's important to know that there are just kind of policy changes, but that doesn't change how the virus works, doesn't change how the bacteria works, doesn't change how they transmit, what type of disease they give you.
Right.
And we know for like decades and decades that vaccines are safe, that they protect, that they save lives. So I think that the message should be that it should be, vaccines do work. Vaccines are not harmful. Vaccine actually protect you against severe disease. So by changing that to the shared decision making, I think that some people will say, if it's not mandatory, maybe it's not as good, or maybe it's not as necessary. And I think that put a little bit of more kind of, work on us pediatricians, because now we're going to have to spend more time in the office trying to explain to parents and families where the vaccines are important, although they are not, mandatory or fully recommended. And as I said, when we look at vaccinations, we don't just look at protect ourselves. We're looking at protect the community. And I think by changing that to a shared decision making, we are probably going to, make some of the population a little more vulnerable to disease.
Along those same lines, let's start talking about measles a little bit. So lots of talk about measles in the media. Would you say legitimate or just a lot of hype?
In regards of if we have a lot of cases and it's getting maybe a little bit out of control, I think it's reality.
Okay.
So, if you recall, in about 2000, it was supposed to be called eliminated from United States. So you have eradication like a smallpox. It doesn't exist anymore. There is not even one case. Doesn't happen. And then you have elimination. Elimination, you still can have a little bit outbreaks, from time to time in certain areas, maybe secondary to somebody that traveled from an area that the vaccine is not as good. They come with the disease and they go and create a small pocket of infections, but it stops there. When we say elimination, it means that there is no continuous transmission of the virus for a year, for 12 months. And we started having outbreak in measles in Texas in January 2005. And we're already in March of 2026. We're about like 14 months into it. And we still have outbreaks and cases.
Clearly not eliminated.
Well, we still,
have the status.
We still have the status of elimination. But if this continues like this, we may lose that status of elimination. So it's a reality. So in 2000, in January 2025 was Texas. Now, in 2026 is moving more to South Carolina, Utah. Texas still has cases. We have cases in Florida, not as much as South Carolina and Utah, but we do have small, outbreaks in the community. So it's a reality, and unfortunately, the cause of that is again lack of vaccination. So for measles, you want to have about above 95 vaccination of your community to be able to have that transmission really low, so it doesn't become again endemic, or you don't have ongoing transmission from person to person. And we, in the country as a whole, we're about 92%. So we're below that 95% threshold to try to stop that.
Yeah. And so even pausing you there for a second, because I think sometimes people hear, 92, that's pretty close to 95%. Does that explain why just a few percentage points make such a big difference?
Measles vaccines just protects 97%. So you still have 3% to get it. Vulnerable people that even with the vaccination, they may get the disease.
And that's not even accounting for immunocompromised people that can't get the vaccine.
Fully immunocompetent with, good immune system that got the 2 doses of the vaccine. So if you have above 95% vaccination rate and you have one case that comes into the country that is infected and is able to transmit, but doesn't have any people around to be able to pass it, then the transmission dies right there. But if you go below that threshold, then that virus finds a susceptible person that was not vaccinated, and that person gets it. And that person finds another one that doesn't get it. And that's how the outbreak starts. So by immunizing more than 95% of the population, you break that cycle, because the person that comes infected, the virus is not able to find another host
Okay.
or another person to be able to continue the transmission. So anything that drops below 95, it gives you a risk. And that's what we call herd immunity, in medicine. So we're looking for herd immunity. So for have that herd immunity, you want to have 95% or more of immunization. Florida, for example, we're at 88%. Yeah, so we are, in a way, the state is susceptible to continue having, ongoing transmission of measles.
So measles by itself is a severe, miserable illness that can have complications such as brain inflammation, pneumonia,
bad lung inflammation, death.
But then there's this weird thing it does to our immune system.
Yeah, we call it immune amnesia.
Immune amnesia. Okay.
So what happens is when your body gets exposed to vaccines, so your body gets exposed to viruses or bacteria, we have different cells in our body. One are called the B cells, one are called the T cells. The B cells are what we call memory cells. So once those cells recognize something, they create memory against it. So let's say that I get a bad case of chickenpox. My B cells are able to recognize the chickenpox, kind of take a picture, memorize it, and say, if I ever see the chickenpox again, I'm going to fight it faster. I'm bigger. So when I get exposed again, they start producing these immunoglobulins that go and bind to the virus and prevent me to have the infection or have the infection really severe. And those memory cells, once you are exposed, they live with you until you die. That's what I call memory cells. Measles infects those cells and kills those cells. So it kills the memory that your body has to fight infections.
Wipes the slate clean.
You become susceptible again to everything that you were, quote unquote, clinically immune, because those cells have died. So you don't have more memory to be able to fight those infections again. And it takes about 3 years to recover that memory again. So for the next 3 years after measles, you are susceptible to things that you were, in a way protected.
Well, I've seen reports that Orange County kindergarten vaccination rates maybe as low as 85%. It's obviously decreasing. It's going in the wrong direction. So as you've kind of already alluded to it, as a pediatric infectious disease doctor, how concerned are you about a measles vaccination rate that still the vast majority, we're up to, 85, 88?
So we are really concerned because, again, we are really below that 95 and it continues to drop. And, kind of the immunization rates started, dropping with COVID-19. And we thought that after, the pandemic was over and everybody was able to go back again to the, to visit with the pediatrician, the vaccinations were going to pick up again, but they didn't pick up. And now we have all these changes, in the
potential legislative changes,
which makes it a little bit more difficult. So I think as pediatricians and in general as healthcare providers, not just pediatricians, because the family doctors, the internists, they have to also do teaching. It's up to us to be able to teach those families and discuss with them the importance of vaccine. I think one of the problems with the general concept of vaccination is that some people believe that they are putting a lot of things in the body of the kids, or why do I'm putting a disease on the body of my kids? And when we vaccinate, those particles that we put, that we give or that we get when we get vaccinated ourselves, that is small tiny pieces of the viruses or the bacteria. So they are not even the live parts of them. We're exposed to many other things on the regular environment, and we are not concerned about that. And every day when we go outside, we go to the shopping mall, we go to to the grocery shopping, we get exposed to so many other things in a way bigger quantity than what the vaccine has. So we have to kind of change that idea that getting a vaccine is that I'm getting something bad on my body.
Do you have ideas on how to change? You feel like the messaging needs to change? What would if you were Surgeon General, or if you were in charge of vaccine messaging for the CDC? I mean, what do you feel turns this around?
I think that is to show the vaccinations are completely safe, that we have a really good tracker of side effects of the vaccines, so they're really well monitored, that they do prevent diseases, and I don't I don't think that showing the bad things that the virus does will actually convince people, because I think that when we see something that is really bad, we said that's not going to happen to me. So we have the opposite effect. So I think that the campaign should be focused on how safe they are, how they prevent those diseases. But it has to be really, really focused in showing that the vaccines are safe, they are well produced, that we have been doing this for decades. That is not something new.
It feels like you can't have an infectious disease talk without talking about COVID. 6 years later, I mean, it's kind of actually 6 years to the date almost.
Mhm.
Where are we with COVID? 6 years later.
So it definitely stay here, and it's going to stay forever. So in the country, and especially in Florida, we see COVID all year long. We do have like maybe two peak seasons. So we have a season that kind of towards the end of summer, early fall, and then we have another one in the winter that is kind of going away right now. We're not seeing as many admissions as we used to see. One thing difficult to track COVID is the CDC is not tracking COVID as used to track it. It's not it is not a disease that they are putting a lot of information. So and many people that have the symptoms, they don't get tested either. So all these flu-like illness that may be COVID, we don't know if it's COVID or not, because people got tired, so they are not getting tested. So maybe the numbers are a little bit higher than we think. I think but we're not seeing the high admission that we used to see. We're not seeing as much mortality, although we still see mortality secondary to COVID, admission to the hospital, visit to the ED. So it's not going away.
Is your opinion, or maybe there's studies that say, is that because the virulence of the virus has changed, or is it because of previous cases people have some immunity?
Is the immunity. So it's what we call probably hybrid immunity. So hybrid immunity is we have the vaccination immunity and we have the natural immunity. So a lot of the kids and a lot of the adults have COVID more than once. And a lot of those adults and kids have been immunized as well. So they have this immunization immunity, and they have the natural disease immunity. So you are not as prone to have it as severe. So that definitely the reason why we don't see it. We don't see it that much. And that's what makes a little bit difficult for the vaccination, because how I'm gonna convince a family to get the COVID-19 vaccine when they don't see in the news that we have 100,000 people admitted, and so many people that have dead, and if I get it, it's gonna be a mild disease. So that the COVID-19 vaccine has dropped significantly. About maybe 10-12% of
I
the
was going to say,
population
teens at the most. Yeah.
is about getting immunized. And the vaccine is still really effective. So it's about like 57-60% effectiveness. As we discussed with flu, you are not looking at not having COVID-19. You are looking at not getting admitted to the hospital with a severe case of COVID-19. But the main reason is that hybrid immunity. Obviously, kids that are 6 months of age, they haven't had COVID because they're really young. So that's probably the population that will benefit the most for the vaccine are kind of the young kids, 6 months to 2 years of age. And I think the older than two, it becomes a lot of
Shared decision making. Yeah.
with the families. So if you ask me as a pediatric infectious diseases, obviously I have to say you have to vaccinate. If you ask me as a parent, and I have to be honest, with some knowledge of infectious diseases, if my kids are healthy, I probably will at this point wouldn't give them the COVID-19 vaccine.
You feel like they have that hybrid immunity from previous infections.
They receive all the vaccines before,
Right.
every single shot they got
Right.
before. So if I have a family that has, a grandpa that is undergoing chemotherapy, for example, that's a family that I will say, I know that your kids are healthy. I know that they probably, had the vaccine before, have the natural disease, so the risk for them to have a severe case of COVID-19 is really low.
Right.
But if they get it, they will pass it to your grandpa that is really, sick, immunocompromised. So
Right.
that family probably they should get the vaccine to
Right.
protect that immunocompromised host that is living around them.
And really, even someone over 65 that's not immunocompromised.
Yeah, so it's
right?
65, immunocompromised, diabetes, obesity,
Right.
hypertension. So it's a lot of those comorbidities that are associated with severe disease.
Is there anything that you feel like the world of pediatric infectious disease physicians learned from COVID?
Personally, I think that COVID-19 taught us that we need to be way better with communication. Because I think one of the problems that we had was all these changes and recommendations every week. And that what, kind of did the mistrust on the community, on the healthcare workers. One day was mask, the other day was not mask. One day was, you can go outside, the other day you have to be locked down. One day was the medication, or there was not, the medication doesn't work. So I think that we learned that we need to be, better with, better with communicating. Or there was a new virus, so it was changing all the time. So the recommendations were changing, there was a dynamic change. I think the collaboration with the private companies was really good, to create testing so fast and to create a vaccine so fast. So I think that was a really good example of,
Public-private
public-private
partnership.
partnership that I think is really, really important. For us, in pediatric infectious diseases, the MISC, kind of understanding that, how those viruses can, you know, produce this overwhelming late immune response, and try to, as you said with Kawasaki disease, try to see if it's the same mechanism as other diseases. So we're learning from that. Long COVID is still there. There is new research coming out about long COVID. So all that is kind of new information and new research and new pathology that we're seeing secondary to COVID-19.
How much of the changing communication was inevitable because it was so dynamic? The understanding was changing, and how much of it was uncoordinated and could have been done better?
I think that if you start by saying that it's a new infection, that we don't know much about it, and that things are going to change because it's new from the beginning, people will understand that every week or every 2 weeks was going to be a new recommendation. But we never said that. We just
given the heads up that almost speaking, humility may not be the right word, but with a lot of contingency, like it seems like this may change, but as far as we know now, this is the best. So a little more qualifiers, you're saying?
Yes, correct. I think that should help for people to understand that things were going to change dynamic and really quick.
And there's sort of a lack of trust in experts of all types, but it feels particularly acute in healthcare. And just we've spent a lot of time just trying to think about what does it look like to relationally communicate with families in a way that fosters trust. And but I mean, your word transparency, just kind of honesty about what is understood and honesty about what isn't understood.
What we do in the hospital with pediatric infectious diseases, there are many cases that we have no idea what is going on. And then we are open with the families from day one. We don't know what is going on. We're going to investigate. So you are honest like that. They will trust you when you tell them, I think that this is what it is. But if you get into a patient room and you said, oh, I'm sure that this is what you have, and then there to be something different, that causes the mistrust.
Let's talk about a few just miscellaneous things, and maybe these will go somewhere, maybe they won't. A little bit of kind of media talk and about TB, tuberculosis increasing, and there was an outbreak, I think, in a high school in California, or when they had a case and they started testing and found a lot of latent TB in a lot of healthy kids. So I don't think tuberculosis is something many parents think about at all. Should they? Is it?
We do see tuberculosis in Florida. We diagnose active pulmonary tuberculosis, maybe 2-3 cases per year in the hospital that we treat. There is a lot of, we don't call it latent TB anymore. It's called TB infection. That's the new terminology.
You call it what?
Tuberculosis infection.
Infection, okay.
So it changed from latent to tuberculosis infection.
The idea being tuberculosis infection, but not illness.
Correct. So
active.
you are infected with the bacteria,
right.
But your body is able to keep it dormant or contained, so you don't have an illness from it.
And was the terminology changed because people didn't take latent TB seriously?
No, it's just that it reflects more what it is.
Okay.
You're actually infected.
You are infected with
the bacteria. Okay. So we do see a lot of latent, tuberculosis infection. And majority of them are just completely healthy with no, possible risk factors. They get tested because they are going to volunteer in the hospital and they come back positive, or they are going to be starting some type of medication that require the testing before starting the medication, and they come back positive. So there is a lot of TB infection that goes undiagnosed because obviously they don't have any symptoms.
I think people think, and I understand this, tuberculosis is like a history book thing as opposed to a current thing. It just read that I think 1 million people each year globally die of tuberculosis still.
We see tuberculosis everywhere in the world. And again, in the United States, we see tuberculosis. Now,
And it's the number one infectious disease killer, I think.
That one, I'm not sure.
Yeah.
I will, as I said, I will be honest. I don't know.
Yeah,
I will
that's
have
right.
to
Yeah.
check.
I think I just read that or whatever. So,
but there's a lot of, the majority of the cases are in, kids that immigrate, to the United States. The treatment has changed a lot. It used to be like 6 months. Now we do 4 months of treatment for many of the cases. So becoming more and more simplified. The treatment for tuberculosis infection have changed as well. Used to be 6 to 9 months. Now we do like 12 weeks of treatment. So that have changed a lot. But there is a lot of tuberculosis infection that goes underdiagnosed for sure.
Lyme disease. There's a lot of talk about Lyme disease. There's way more talk about Lyme disease often than there is real illness.
Lyme disease.
Yeah, than real Lyme disease. But there is some expansion of the geography of Lyme disease that like more into some of the eastern states. And
yeah, we used to say many years ago that it was all the Northeast. That's right. And
Right.
then if you were coming from the Northeast, you have Lyme disease. If you were in Florida, you didn't have Lyme disease. Obviously, those ecosystems are changing a lot, and with global warming and things like that, we're starting to see a lot of the diseases, coming more like south and to different areas. We still don't see truly Lyme disease transmitted in Florida yet. So the majority of the cases that are diagnosed, what we call imported cases. So travelers, yeah. Correct. The difficult part is there is a lot of misconception with the terminology of the chronic Lyme disease. So a lot of kids or adults that have, kind of unspecified symptoms as, fatigue, headache, joint pains, they want to blame it on chronic Lyme disease. Chronic Lyme disease does not exist. Once you treat Lyme, goes away. Some people that do have acute Lyme disease, they may develop those kind of symptoms of maybe fatigue and joint pain after the disease, but it goes away. So the terminology of chronic Lyme disease that the bacteria lives in your body forever does not exist.
That needs treatment.
Needs treatment. And unfortunately, there is healthcare workers in the community that they have all these private practices and they sell this idea of we treat chronic Lyme disease, and they offer different treatments as IVIG, prolonged antibiotics, IV antibiotics, and nothing of that has really any kind of clinical evidence for that.
There is currently right now in the news, actually my wife and I were listening to it today, but a Lyme vaccine that's in some stage of study. And that's happened in the past too. I think there's actually been one approved in the past. They just never really got much uptake.
There's a lot of research right now on vaccinations.
So to summarize that maybe would be, though the geography of Lyme disease is expanding, really hasn't expanded this far south. We do have the ticks that transmit it, but the ticks that we have don't carry the bacteria.
We don't have the bacteria yet.
Okay, great.
Now, I will imagine that in decades from now, with all the, changes on the ecosystem, we probably will start, seeing cases endogenous from the region. But right now, the cases are all what we call imported. Something
that comes up in the office a lot, the whole concept of, in the title of strep throat, but strep carriers. Mm-hmm. How would you explain that in a simple way? Because it's a tough one sometimes. If a child comes in, gets tested, and is positive, to be told that, oh, this is likely not an illness that needs to be treated. This is likely carrier. Mm-hmm. One, I think that's a little bit hard to understand. Well, why do they not need to be treated? And then, so are they permanently a carrier? And so explain strep carrier for us a little bit.
The difficult part is that we shouldn't test if we don't have the clinical symptoms for the disease. That's right. So
irresponsible testing is going to have a lot of positives that aren't illness.
And that happens to us in healthcare work all the time. We send tests and then we get the test back and we have no idea what to do with the result.
Yeah, that's not a parent thing. That's on the clinicians.
That's on the clinicians, right. Correct. We were not expecting that result. And now what do we do with the result? So something like that happened with the strep. So I have a 1-year-old that comes with a lot of runny nose and congestion, I shouldn't be testing for strep. Because that's not the clinical symptoms that a strep will give me, and that's not the typical age that a strep will happen. So if I have a patient that is 7 years of age and I happen to do a strep throat test just because, and it comes back positive, then that's a carrier. That's right. You are detecting the bacteria and you are asymptomatic. Now, the truly definition of carrier is someone that has recurrent, truly disease, and between the episode of treatment when they're asymptomatic, they don't have any symptoms, they continue to be positive. And a lot of us were carriers of many things, not just a strep. We're carriers of a staph, we're carriers of a strep pneumo, we're carrier of, H flu, pseudomonas, and a strep is one. The strep is one of them. And it gets difficult because they try to think that being a carrier will predispose you to have more of these acute illnesses or of infections. And then we can go into treatments and things like that and recommendations. We do offer off the books treatment for carrier because if you look at the actual recommendation, it has to be for someone that lives with someone that has a high risk for rheumatic fever or have a history of rheumatic fever. And those are the cases that you truly treat the carrier. Because even if I treat the carrier and I eradicate, that person the next day can go to school and get the bacteria again.
Why would latent TB not be called TB carrier?
Well, because that one is an actual infection that is in your body and it can,
And you're saying this is more just hanging out colonization as opposed to an infection.
Correct.
Okay.
And many of the issues with the strep that we see in the practice, the patient that get referred to us is they get treated for a strep, like a true disease. And a week after, either the parents request the test or the physician wants to do a test of cure and test again.
Which isn't recommended.
It's not recommended.
Right.
And it comes back positive again. So, the treatment did not work. And the treatment did work. Your symptoms went away. It's just that the bacteria is just living there. So the test of cure is not recommended for a strep.
I mean, I don't know if these numbers continue to be accurate. I've heard that of school-age healthy kids, 15% will be. So if you just took a class of third graders and tested everybody, 25 kids, you're probably going to have three or four kids positive for strep.
And without having any symptoms at all. And going back to that kind of colonization is the issue that we have now with this molecular testing that is being offered to practices. So you have, they come and they offer this great test that I put a swab on your nose and I'm going to test for 50 bacteria, 30 viruses in one single test. They are great. That's right. You are testing 50 things at the same time. But majority of them are being colonization. So you have all this coming back with all, you are infected with, 4 bacteria at the same time and 3 viruses. And then they come to the offices, you're not infected with anything. They are just living with you because it's normal that those things coexist with us.
This is the PEDS ID version of a full body scan. You just start finding things that aren't,
And we do use some of those testing, but when we have certain clinical scenarios that we need to rule out some things.
Well, the majority of which is a sick child. I mean, the starting point is it's a sick child as opposed to a
but doing that kind of a gunshot approach is not recommended because you're going to find a lot of these bacteria that they coexist with us.
Yeah.
And viruses that live with us too.
Yeah. 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 I think the last time you were with us, you talked about, we did get into the idea of diagnostic stewardship as far as being smarter about the test we do. Speaking of last time you were with us, you had mentioned that the field of medicine, which you've already talked about again, needs to adapt in the way we communicate. Anything further you'd say about that as far as another year has passed, specifically, how do you think we need to communicate differently?
So, having teenagers in my house, I think that has to be through social media. I think that's the way to do it. They keep on this phone just scrolling to, TikTok videos and, Instagram videos. So if you're able to make, small videos that are really catchy for them with, things that are true, it will get into their heads. And the same, for, young adults. I think that's the way. I don't think that they are not to go, they don't watch TV anymore. So there is no the advertising on the TV, it's all, streaming, and so it has to be through social media. It has to be the best way to do it.
Another thing you said last time you were with us is that you thought it would be more likely we'd have a pandemic before the Magic won a championship. You still feel that way?
Well, I don't know, but maybe not a pandemic. We're seeing a lot of measles, so I'm not sure.
Yeah. But the magic are also getting better every year.
Yeah, so maybe, hopefully no.
Hopefully it'll be the magic.
Hopefully no.
Anything that scares you as a pediatric infectious disease doctor? Anything we haven't talked about that, or maybe that we have talked about?
I think that is going to be the fact that we probably will see more novel viruses, and it's because all the changes on the ecosystems. So I
And
think
when you say that, it's population growth and
population
travel.
growth, the traveling it's more easy to travel to other countries and then to bring things that we are not used to see. So again, our bodies are not used to recognize those things. Is going to going more into rural areas and start expanding the urbanization. So you kind of displace all those most of those animals, for example, that they have their own viruses and bacteria, so they become more you become more prone to be exposed to those. So I think as a pediatric infectious diseases, we are always kind of on the look for those kind of changes. We got the many years ago Ebola, and then we got COVID-19, and we got the swine flu, and now we have the outbreak of measles. So we are always going to be kind of looking for that next thing that may come, and try to be prepared for that.
How do you stay up to date? How do you what do you do you still read your journals?
Yes. So we have, I read one that is called Clinical Infectious Diseases. One is called Journal of Infectious Diseases. There is the Peds Society Infectious Diseases Journal. That are kind of the three main for infectious diseases. I still, I don't read it, but I go to the table of contents of regular pediatrics.
Find the ones that are
Find the ones that are, that I'm interested into. I try to stay away from artificial intelligence. I still don't find that is totally
Do y'all have
reliable.
little Reddit areas of PEDS ID people where you get
No,
together and chat?
Before it became X, Twitter was really good.
Okay.
So the ID community was really active in Twitter, and they putting the last things, and the last testing and medications, and there were really nice discussion about clinical scenarios and the last papers and journals that were
And
coming
did people
out.
just get off when it became X?
Yeah, they are not posting as much that they used to be, but that was a really good source just to see what was going on. After that, you go and look for yourself. But yeah, we still read, we still read every issue of every journal regarding infectious diseases. I'm sad that the new generation don't look at journal that much and at books that much. They just do all kind of online, up to date, and
Yeah, in our journals, you have so many services that curate the articles for you, and so we still get pediatrics, but there's a lot of email services that basically give you the table of contents, and then you can choose the ones that
you want to read.
Yeah, because it's hard. I mean, a lot of our journals, it's a lot of things that don't apply to an outpatient pediatrician at all. A lot of hospital based, and a lot of.
I do the same thing. I just go and look for things that I'm interested in.
Anything else you'd want to share with our families, just about anything we've talked about flu, measles, vaccines? It just, people ask a lot about, hey, my kid gets sick a lot. Is there anything I can do to boost their immune system? Are they sick too much? And just whether it would be words of comfort or words of caution that you would pass along to families.
We see a lot of these kids in the office as well, because the parents, they come with the concern that they get, sick a lot. We try to tell them that it's normal, and actually is good in a way to get some of those illnesses, because that's the way that your body gets those memory cells. There are really nice all studies that have shown that when kids go start daycare or start kindergarten late, the first 2 years they get an average of 2 diseases per month, with an average of 10 days of each illness. So a kid usually, when they start daycare or they start late kindergarten or pre-K, about 15 to 20 days of each month they're going to be sick.
They have symptoms more than they don't.
Yes, and that lasts for about 2 years before you create that clinical immunity and you're able to fight infections easily. And they could be from anything from a runny nose to a cough to diarrhea to vomiting to skin rash. So the important thing is that will pass and they will get stronger. and they're not going to have it as much as frequent. We get a lot of, questions. How do I boost my immune system? How do I make sure that the kid doesn't sick, and it's, basic things, good nutrition, good sleep, good exercise. And with that, that's there is not a magic medication to boost the immune system, but, if they have a good routine for sleep, a good routine for exercise, a good nutrition, that's the best thing that you can do for your body. And then obviously we have discussed, during this time is vaccinations are really important.
Great. Well, we so appreciate you. I know I told you last time, just as far as the way you serve families in the community, and you serve a lot of families in our community, and they have no idea who is sort of who's behind the curtain on the other side of the phone, as far as, so we just appreciate you and appreciate you sharing with us tonight.
No, thank you very much.